Hello, everyone, and welcome to our module on restrictive lung disease. So restrictive lung diseases are chronic lung conditions where the lungs can't fully fill with air like normal. That's why they're called restrictive, because there's some restriction to the normal expansion of the lungs. And in the video on pulmonary function testing, I talk about the spirometry test results you expect to see in restrictive lung diseases. So let's review that now. So first of all, the key point to remember about spirometry in restrictive lung diseases is that you can't get air into the lungs because there's some restriction to lung expansion. Therefore, when you do a spirometry test and you ask the patient to exhale forcefully, less air is going to come out compared to normal. So this means that the forced vital capacity is going to fall, the FEV1 is going to fall, but importantly, the ratio of FEV1 to FVC is going to remain above 80%, which is normal. And this is the hallmark of restrictive lung diseases by spirometry. In obstructive diseases, this ratio falls, but it remains normal in restrictive disease. And I've shown that on this graph here on the slide, which I review in detail in the video on pulmonary function testing. And then lastly, in restrictive lung disease, remember, it's hard to expand the lungs. So patients tend to take shallow breaths so that they don't have to do as much work expanding the lungs like they would if they took deeper breaths. And because they're taking shallow breaths, they breathe faster. So they tend to breathe with rapid, shallow breaths. And this is because there's increased resistance to lung expansion in restrictive lung disease. So that's spirometry, but what about other volumes in the lungs, like the residual volume, the total lung capacity, the functional residual capacity? Well, the easy way to think about all of these volumes is that they decrease in restrictive diseases. Less air fills the lungs because of restriction, so all of these volumes up here fall. And that's the opposite of what happens in obstructive lung diseases. In those conditions, there's air trapping, and so all of these volumes tend to go up. There are two broad categories of causes that lead to restrictive lung disease. The first is poor breathing mechanics. So in poor breathing mechanics, the lungs are completely healthy and normal, but there's something wrong with the chest wall or the nervous system or the spine, and this prevents the lungs from filling normally. So for example, if you look at this slide on the screen here, the first red graph is a patient with normal lungs. So they can fill their lungs all the way up to 6 liters, and then they can blow out air all the way down to a residual volume of just under 2 liters. Here's a patient who has kyphoscoliosis, which we'll talk more about in a second, but it's a severe curvature of the spine, and it prevents the patient from fully inflating the lungs. And so you can see that the amount of air the patient can get into the lungs and the amount of air that the patient can push out of the lungs is much smaller compared to normal. This is not a lung problem, it's purely a problem with breathing mechanics. The second broad category of causes of restrictive lung disease is interstitial lung diseases. We'll talk a lot about these in this video. These are conditions where something builds up in the tissue of the lungs and that prevents it from expanding. So for example, in pulmonary fibrosis, you get fibrous tissue in the lungs, and you can see that that creates much smaller lung volumes, just like kyphoscoliosis does. But this is a problem with the lungs themselves. This is not a problem with the lungs. It's a problem with breathing mechanics. So poor breathing mechanics, as I just said, is not a primary pulmonary issue. It refers to underventilation of the lungs due to some problem with the chest wall or the spine or the muscles or the nerves that all have to work together to cause the diaphragm to contract, cause the chest wall to expand, and therefore the lungs to fill with air. Importantly, the lungs are entirely normal, so the alveoli are working. The AA gradient will be normal. The DLCO, which is a measure of the diffusing capacity of the lungs, will also be normal. We'll talk more about DLCO later, but it's completely normal in patients who have restrictive lung disease from poor breathing mechanics because the lungs themselves are healthy. So what are some of the conditions that can lead to chronic restrictive lung disease because of poor breathing mechanics? Well, if there's anything wrong with your neuromuscular system, this can cause this problem. So people who have ALS or polio or myasthenia gravis, they basically can't contract their diaphragm normally in order to fill the lungs with air. You can also have patients who have structural problems. So if there's a scoliosis of the spine that's severe like this, or morbid obesity, these things can prevent expansion of the chest wall, and they can also lead to restrictive lung disease due to poor breathing mechanics. So the other broad category of causes of restrictive lung disease are the interstitial lung diseases, also called diffuse parenchymal lung diseases. They get these names because the interstitium is the tissue around the alveoli, and that's what's abnormal in these conditions. The parenchyma refers to the functional tissue of the lungs, and that's also abnormal. So that's why these are called interstitial or parenchymal lung diseases. Importantly, they are diseases of the lungs themselves, where there is a problem with the lungs. These are a large group of disorders. We'll talk about many of them in this video. They have similar clinical and radiographic findings. And importantly, the lungs are not working normally. The problem is in the interstitium, which is the tissue surrounding the alveoli. And because the lungs aren't working normally, these patients will have spirometry that indicates restrictive lung disease, but they will also have an increased AA gradient and an abnormal DLCO. And this is different from poor breathing mechanics. Those patients will have evidence of restrictive lung disease on spirometry, but these measurements right here are totally normal. So let's talk in detail about the DLCO, which stands for the diffusing capacity in the lung of carbon monoxide. This is a test we perform on patients that measures the ability of the lungs to transfer gas to red cells. The way this test works is the patient inhales a small amount of carbon monoxide, not enough to be dangerous. You may know that carbon monoxide is a poison and large amounts can be dangerous. I talk about this in other videos, but in this test, a very small amount is inhaled. And in the videos on pulmonary physiology, I talk about how carbon monoxide has diffusion limited uptake. That's what's shown here in this graph, which I go over in detail in other videos. And what this means is that the amount of carbon monoxide taken up by the patient's bloodstream is proportional to the diffusing function of the lungs. So the patient inhales a small amount of carbon dioxide and a sensor measures what they exhale to see how much was picked up by the bloodstream. The normal result is 75 to 140% of what's predicted based on the patient's size and other factors. Severe disease is less than 40% of predicted. So measurement of the DLCO can be very helpful in identifying the cause of restrictive lung disease. If a patient has restriction based on their spirometry, like we saw a few slides ago, but their DLCO is normal, this means they have extrapulmonary disease, for example, obesity or scoliosis or ALS or some of those things we talked about before. If they have restriction by spirometry with a low DLCO, then that means they have some form of interstitial lung disease. And so, for example, if you look at this table here, which comes from a textbook, don't worry too much about these numbers at the top, but look at the DLCO along the bottom. This is a patient with pulmonary fibrosis, which is a form of interstitial lung disease, and the DLCO is 60%. And then this is a patient with obesity, which is a cause of restrictive lung disease through poor breathing mechanics, and you can see that the DLCO is almost 100% of what's predicted. So all the disorders shown on this slide are conditions that can cause a low DLCO. The big one is interstitial lung disease. But you can also find a low DLCO in emphysema. If there's some problem with blood flow through the lungs, like pulmonary hypertension or pulmonary embolism, this can reduce the DLCO. Patients who've had large amounts of their lung resected for some reason can have low DLCO. And then anemia also can lead to a low DLCO, although if you correct the DLCO for the hemoglobin level, it will be normal. But of all these causes I've listed here, this one is the most important. And why is that? It's because in interstitial lung disease, patients routinely have the DLCO measured in order to monitor their disease progression. Left untreated, the DLCO will fall year after year in patients with progressive interstitial lung disease. And when we administer treatment for those conditions, we hope that it stabilizes or increases the DLCO. We don't usually measure DLCO regularly for all these other conditions listed here, but it is a regular measurement done to monitor the progress of interstitial lung disease. So there are many, many causes of interstitial lung disease, but on this slide, I've listed some of the important ones that I'll go through in this video. These are the ones I think are important to know for your Step 1 exam. But remember, most likely, they're not going to ask you super detailed questions about these conditions, some of which are very rare. Instead, they're just going to want you to understand the expected spirometry and lung volume results you would get in all these conditions, and that's the information I went over at the beginning of this video. So first of all, we'll talk about idiopathic interstitial pneumonia in just a minute. This is basically an idiopathic form of interstitial lung disease. There are a number of systemic diseases which often have interstitial lung disease associated with them. Scleroderma is a big one, but also rheumatoid arthritis. You can also see it in Goodpasture's and Wegener's granulomatosis. You can also see it in sarcoidosis, and there are others beyond this list. Pneumoconiosis refers to occupational exposure to toxins that cause interstitial lung disease, and we'll talk about these. And then we'll finish this video by talking about these last three conditions here as well. Shown on this slide are the CT scan and X-ray findings that you often see in interstitial lung disease. So even though there are many different causes of interstitial lung disease, most of them lead to radiographic results like what's shown on this slide. So first of all, in the CT scan on the left, hopefully you can appreciate that there are bilateral diffuse abnormalities. And what you have is this sort of honeycomb lung appearance. It's fairly easy to recognize, even if you're not used to looking at CAT scans, so try to remember what this looks like. The abnormalities are often described as small irregular opacities. The term used for this honeycomb appearance is reticulonodular, and you'll hear that. And then you can also see the same thing on this X-ray over here. You can basically see that there's a lot of white on both sides of the screen, and the white has this sort of wispy, streaky type of look to it. That's sort of the honeycombing or reticular nodular appearance of interstitial lung disease on chest X-ray. Okay, so now we'll go through all the causes of interstitial lung disease, and we'll start with idiopathic interstitial pneumonia. This is a form of interstitial lung disease which has multiple subtypes. The etiology is unknown, and it always involves an expansion of the interstitium. And the interstitium, like I said before, is the part of the lungs that surrounds the alveoli. It's the area between the epithelial cells in the alveoli and the basement membranes. And this interstitium fills up with an inflammatory infiltrate, sometimes with fibrosis, and that's what's known as idiopathic interstitial pneumonia. Idiopathic interstitial fibrosis is the most common subtype of idiopathic interstitial pneumonia. Patients develop the classic interstitial lung disease CT scan, like what I've shown on the slide here. They have an associated slow onset of dyspnea. It usually affects older adults over the age of 40. And biopsies have been done of the lung tissue in these patients, and what they see is a decrease in the number of type 1 pneumocytes. These are the pneumocytes that are important for gas exchange. They see a rise in the number of type 2 pneumocytes. These are the pneumocytes that are important for repairing the lungs. And then they see an increase in fibroblasts. And this is fairly easy to understand. Basically, you're having damage that's causing you to lose the gas exchange pneumocytes. The lungs are trying to respond and repair the tissue. That's why there's more type 2 pneumocytes. And then fibroblasts are being drawn in, and that's what's leading to the fibrosis of this condition. Okay, next cause of interstitial lung disease is the pneumoconiosis disorders. These are all occupational lung diseases. They happen to people who work in certain environments where they can inhale dangerous substances. So there can be coal miner's lung, and coal miners, obviously. We'll also talk about certain occupations where people can develop silicosis or asbestosis. So coal miner's lung is a condition that occurs in coal miners, obviously, and it's caused by inhalation of very small coal dust particles, which become lodged in the interstitium of the lungs, and they lead to interstitial lung disease with restrictive spirometry and all the things we talked about earlier in this video. When you do a chest X-ray or chest CT, you see small, rounded nodular opacities, very similar to the X-ray we saw earlier. The dust particles tend to have a preference for the upper lobes, although this problem can involve the entire lung. And this is just a picture here of a lung of someone who had coal miner's lung disease. And you can just see the black particles all throughout the lung tissue. Silicosis is another occupational lung disease that occurs when patients inhale small amounts of silica, which is an element found in many rocks. So you can find it in quartz or granite or sandstone. It's the most widespread pneumoconiosis in the US. It occurs in workers who work in foundries, which are metal production facilities. It also occurs in workers who do sandblasting, which is a form of abrasive blasting. And it can also occur in people who work in mines where they mine these substances here. What happens in silicosis is when the small particles of silica are inhaled, the macrophages in the lungs react to this. This leads to inflammation, which draws in fibroblasts that lay down collagen, and that leads to fibrosis of the interstitium, which causes restrictive lung disease. Two sort of quirky trivia things to know about silicosis. Patients with this condition have a high prevalence of TB. That's because the macrophages react to the silica and they become impaired, and then they can't kill the TB. Also, patients with silicosis have a high prevalence of bronchogenic carcinoma, which is a form of lung cancer, and I talk about this in more detail in the video on lung cancer. Just like coal miner's lung, silicosis tends to affect the upper lobes more than the lower lobes. This is an X-ray of someone with silicosis. You can see there are a lot more white infiltrates in the upper lobes compared to the lower lobes. And then the lymph nodes can become calcified in patients with silicosis, and you can see the calcium looking like an eggshell around the lymph nodes in a chest X-ray. This is not really shown that well in this example right here, but you can look at other examples online. And so these eggshell calcifications of lymph nodes are sort of a classic finding in silicosis. And then our final form of occupational lung disease that we'll discuss is asbestosis. This occurs when workers inhale asbestos fibers. Asbestos fibers are industrial fibers that are used in a number of industries. Shipbuilding is a classic industry for exposure to asbestos, so is roofing and plumbing. And workers who work around asbestos normally wear protective equipment like what's shown here, but years ago, when asbestosis wasn't as widely understood, people were heavily exposed to this substance. Unlike silicosis and coal miner's lung, asbestosis classically affects the lower lobes, not the upper lobes. And when you inhale asbestos fibers, it can lead to 3 different clinical problems. One of these is interstitial lung disease, which is called asbestosis. But asbestos can also cause pleural plaques to form, and it can lead to a very rare form of lung cancer called mesothelioma. In patients who have interstitial lung disease from asbestos inhalation, which is asbestosis, if you do a chest x-ray, there is a classic finding, and that is the presence of calcified pleural plaques. This finding is pathognomonic for asbestosis, meaning if you see it on a chest x-ray, it's diagnostic of asbestosis. This x-ray image on the right side of the screen here shows some pleural plaques where the black arrows are pointing. These findings are not easy to appreciate if you're not used to looking at chest x-rays. I don't think they'll expect you to recognize this finding without giving you lots of other clues in the question stem that the patient has asbestos exposure. And then in terms of path findings, if you do a bronchoalveolar lavage or you look at a sputum sample, you can sometimes see asbestos bodies, which are also called ferruginous bodies. The word ferruginous means containing iron. And so what these are asbestos fibers surrounded by a coating of iron and protein that comes from macrophages. This is a picture of an asbestos body on the slide here. Sometimes they have sort of a dumbbell shape like this, where they're narrow in the middle and wider at the edges. But the point is that you can see these fibers of asbestos sometimes in a sputum sample or a bronchoalveolar lavage sample. In terms of cancer, there are two things to know about asbestosis. First of all, patients with this condition can develop bronchogenic carcinoma, just like you can see in other forms of occupational lung disease. But then there is a very rare form of cancer called mesothelioma that is linked to asbestos. In fact, asbestos exposure is the only known risk factor for mesothelioma. This lung cancer occurs decades after exposure. It involves the pleura. The pleura become thick and pleural effusion typically develops. Patients present with a slow onset of symptoms like dyspnea and cough and chest pain, and it has a very poor prognosis. And there are lots of legal cases related to patients who develop mesothelioma who worked in industries where they were exposed to asbestos many decades ago before proper personal protection equipment was advised. Okay, there are a number of drugs that can lead to interstitial lung disease. Some of the important ones I've listed here. So bleomycin and busulfan are anti-cancer agents. Amiodarone is an antiarrhythmic drug, and methotrexate is an immunosuppressive drug. And so, for example, this is a patient on the left before bleomycin. Usually when patients start these drugs, they have a baseline chest x-ray that can be used for comparison later. And here's the patient after bleomycin exposure when they've developed some interstitial lung disease. You can see those wispy white reticulonodular findings starting to appear in both lung fields. Hypersensitivity pneumonitis is another cause of interstitial lung disease. This is a condition where patients have a hypersensitivity in the lungs to some environmental antigen. So for example, agricultural dust can cause this. Certain microorganisms like fungi, bacteria, or protozoa can do this, and certain chemicals. In terms of immunology, it's a mixed type 3 and 4 hypersensitivity reaction. The classic example of hypersensitivity pneumonitis is farmers' lungs. Farmers are exposed to moldy hay or grain, and this can lead to this condition. You can also see it in patients who work around birds and poultry. The waste from the birds can become dried and finally dispersed into dust, and when they inhale that, they can develop a pneumonitis. So in terms of clinical presentation, this can present as an acute condition. In someone who is just exposed to one of those things we talked about in the last slide, they can acutely develop cough, dyspnea, chest tightness, crackles throughout the lungs. This is often, in terms of a board question, going to be in a farmer or a bird handler. And these symptoms will resolve if the trigger is removed. In other words, if they stop exposing themselves to whatever's triggering the pneumonitis. But in patients who chronically are exposed to these things and continue to work in these environments, if they have ongoing chronic pneumonitis, they can eventually develop diffuse fibrosis. And this is what can lead to interstitial lung disease. They sometimes develop a special form of bronchiectasis called traction bronchiectasis. So I talk about bronchiectasis in another video, but it's a dilation of the airways. And in traction bronchiectasis, what happens is fibrous tissue pulls and dilates the airways, causing bronchiectasis. Normally, it's associated with chronic inflammation within the airways. In traction bronchiectasis, it's because of fibrous tissue outside the airways pulling and dilating those airways. You can also see among patients who are chronically exposed to triggers for hypersensitivity pneumonitis formulations of granuloma. In the immunology section, I have a video on vasculitis disorders, and two of those disorders can be associated with interstitial lung disease. The first one is GPA, which is granulomatosis with polyangiitis. The other one is MPA, which is microscopic polyangiitis. They're both forms of vasculitis. They're both ANCA-associated disorders. I talk about ANCA antibodies a lot in the video on vasculitis. ANCA stands for anti-neutrophil cytoplasmic antibodies. Both of these conditions are so-called pulmonary renal syndromes, so they can cause nephritic syndrome in the kidneys, but they can also have lung involvement, and they can lead to interstitial fibrosis. And then the final cause of interstitial lung disease that we'll talk about in this video is radiation-induced lung injury. So this occurs among patients who have chest radiation for malignancies within the chest, like lymphoma or lung cancer. So first of all, when you have chest radiation, an acute pneumonitis can develop a few weeks after chest radiation, and this can lead to symptoms like cough and dyspnea. But 6 to 12 months later, that's when patients can develop interstitial fibrosis, which is a cause of restrictive lung disease. The initial pneumonitis can cause a dry cough and dyspnea, sometimes with a low-grade fever, although it's often asymptomatic. But then months later, as I said, this can lead to fibrosis. The reason this is believed to occur is because the radiation can generate free radicals in the lungs, and that leads to cell death, and that causes inflammation. And there have been a bunch of basic science studies on this looking at the pro-inflammatory cytokines that are common in radiation-induced lung injury. Some of them are listed here. They can be elevated in the serum among patients who have had chest radiation. This includes things like TGF-beta, TNF-alpha, and IL-1 and IL-6. I think knowing all these things is fairly low yield for your step 1 exam. Mostly what they're going to want you to know is that radiation-induced lung injury leads to restrictive disease, and they're going to want you to understand the spirometry and the lung volume results in these patients. And that concludes our module on restrictive lung disease.